Hello, welcome to the webinar of Do You See What I See? Mastering Radiographic Techniques and Interpretation for Pediatric Dental Patients. My name is Dr. Jacob Lee. I'm a pediatric dentist practicing in San Clemente, California. So greetings to you all. Let's begin. Your water tastes funny. A number of years ago, I used to have lunch with a general dentist in town, and occasionally we'll get together and over lunch and talk about our families and our community and so forth. And one day when I met him for lunch, he didn't look too good. And I said, "What's wrong? What happened?" And he told me what happened. One day, one of his patients said, "You know what? Your water tastes funny." And he said, "Why? It shouldn't. It's from our bottled water. It's distilled water." He said, "Oh, maybe that's just me." And then after a while, he said it again, "But your water really tastes funny." So he asked his assistant, "Where'd you get the water?" And the assistant led him to the dark room where she poured the X-ray developing fluid into the water bottle, not knowing that that's not supposed to be given. And he said that was the worst time of his life. And the patient had to be transported to a hospital and stay overnight. And patient was fine, but he said that was the worst time of his life. So until then, I was procrastinating whether to change from the traditional radiographic system to a digital one. But that really prompted me to change my the way I practice dentistry. At this time, I'd like to thank the Air Techniques for sponsoring this presentation. Much appreciated. And as I begin with all my presentation, let's start with a little quiz. So, you're looking at a fracture. How many fracture lines do you see? Would you say 3? Would you say 2? Or would you say 1? And we'll come back to that during my presentation. So today's presentation is a little different because it's not a lot of data crunching presentation. It's more of what I've learned, I'm sharing with you. So I spent half of my professional career in dentistry teaching in academics. And then the other half, I opened a practice in 2001 and with my wife to eke out a little living and pay for my kids' college. And so a number of the cases that I've gathered over the years, as well as my own experience, I'll be sharing that with you. So let's start with the systems. There are certain types of systems. One is a sensor type. In late 1990s, someone gave me SCHIC system to test. It's a sensor at the time, and to be honest with you, it was the size of my wallet, the size and the thickness. And I was just shocked at how anyone could use that. But you can see over a period of time, like anything, they have reduced this in size and made it better. One of the other popular ones that I hear from my colleagues is Gendex. You can see comparing with SCHIC, the edges are smoother and much thinner. And then also another popular one is Dexis. It's a sensor system. So how about others? Types of X-rays, of phosphor plates. Actually, the proper name is photostimulate level plates system is what it's called. And but we just kind of call it the PSP or phosphor plates technology. And there are many different types, Carestream, there's Apixia, and there's Acteon. And one I use in my practice is ScanX at the very bottom one. And the reason I picked phosphor plate system or photostimulable phosphor technology is that the film itself was very flexible. As you can see on the right, it almost mimics the regular traditional. And so it was very easy to work with in terms of the size. It's thinner than the sensors, and it was better tolerated. And of course, I surveyed my colleagues who were using a digital system at the time, and they seemed to like the system. And you're able to use the bite wing tabs. And of course, it was really easy for the staff to transition from the traditional one to this one. Now, I'm going to give you a little tip on using this because one of the complaints was that when the children bite down to have anterior radiographs taken, that they can leave bite marks. So what we did was we bought this little clear X-ray cleaning film, and we cut the size, and we put one on the top, one on the bottom, and close it up. And when they bite down, then they will never leave a mark. So that's just a little tip for you. So that's what we've been using, and we've been pretty happy with it. Because another reason is, we're going to talk about a bit about gagger. And especially with gagging patients, this seems to work really well with gagging patients, and we can use that. And of course, because this one, the serration will leave mark on the phosphor plate, so this one will enable to be used repeatedly. And the cost is much less than the sensor to begin with. Now, I'm in kind of about a fourth, going on to fifth generation of Scanix. And the one in the middle, I just took a picture from the office, and that's what we currently mostly use. And because in pediatrics, volume is our practice, so we need actually a couple of them. So we are running a couple at the same time. So that's one of the, and this one is a dual from Air Techniques, and it's really fancy one. And I also heard that they have attached a sensor to this one. So it's like McDonald's selling burgers as well as salads, so to make everybody happy. So that's the system. But it really comes down to what you really prefer. They all cost almost as much as Mercedes, Porsche, or BMW, or Tesla. But it really comes down to your budget, what you really are capable of, and what you really like from your colleagues, and what works really in your hands. And sometimes you have to go with budget, and work your way up. And I don't mean to knock Kia, because it's a nice Korean brand, but it's something that we work towards having, better cars and so forth. It's a better system. But talking about better system, when I bought the pen system, just to complete the whole segment, I bought a used Progeny, and I could not afford an expensive new one. So it worked its way for a long period of time. And finally, recently, I got this, which is a much better one, Ortho, and it has worked as well. Now, in terms of the X-rays, you've got to be able to not only take X-rays, but transfer to dental management software. And of course, the big players are Dentrix and EagleSoft. Now, the one I use in my practice is from KSP Dental. It's called Docs iPedo software technology, and it's originally made for pedo and ortho, but now expanded because our pediatric population has grown, so has the company, so it encompasses the general practice as well. Now, in terms of taking X-rays on children are not inanimate objects because they move around, they have feelings and so forth, unlike cars. So we have to think of that. And what we think of that also is the child is really not a small adult. And sometimes we make that mistake, that we think of child as a smaller version of an adult, but they're different, as we come to realize, because they're physically, emotionally, psychologically, mentally, physiologically, and you can add so many alleles, because they're totally different beings. So we have to kind of keep that in mind as we address them. So when we talk about history of guided narrative symptoms, one of the critical part I find is getting that information beforehand, and also talking about past dental care and oral hygiene, because it kind of gives me some hint to the past experience of the child in terms of getting dental care. And of course, that includes prophylaxis and radiographs, but also oral hygiene, because it also helps me to assess risk management going on with radiographs as well. So it starts from the beginning. If it really takes a village to raise a child, it really takes a whole office to make that a success. So making appointments, patient scheduling. So if it's a youngster, booking in the morning, and you also give, depending on the behavior of the child in the previous experience, you want to give it enough time, and also patient traffic as well, because you want, when you're taking radiographs and suddenly the child does not behave the way you want to, you don't want the whole office to be backed up. So you have to have a lot of plan Bs in that regard. So if there's a behavior issue that you think about, there's time to make adjustment. You have to make that adjustment and be ready for it. And sometimes they can be confounding, because children are a little different in that sense. For example, children can take everything very literally. So you cannot give mixed messages. You have to give them the message. Like on the slide to the right, it says do not enter. At the same place says entrance. Well, children don't understand that. I remember a long time ago, I asked my son what he wanted to be, and he said, I want to be a chair. And at the time, I was a chairperson of Pediatric Dental Department at the University of Pacific. So I thought, oh, he wants to follow my footsteps. So he wants to be chair. And he said, no, I want to be a chair. And I said, well, why not fireman or anything like that? And he says, I don't know how to fight fire. I'm glad he didn't stay as a chair because now he's a pediatric dentist and working as my partner in my practice. So, but children are very literal in that regard, so we have to take that into account. This was my best patient, and he walked in. He said, Doc, I chipped a couple of my teeth, and I would like you to help me out. And he literally was such a wonderful patient. But not all patients are like that. Many of them are withdrawn, they're shy, and you have to keep that in mind. But also sometimes they can be a little off the wall. They can be combative. And sometimes they could, I almost saw one child almost destroying my dental chair. So they can be a little disruptive as well. But on top of that, there are times, not all the time, children who just behave in a different way. You can call them princes, they're in a different world. But in a family of 3 or 4, I always seem to see, and of course, this is not statistically valid, but more of impression, that they are a little different. At least one is different. And they just work, march to a different drummer. But we think it's just recent, but it was a long time ago as well. It's just that people have not kept good record of that, I guess. But that there is a parents, in form of equity, I put potential mom and dad together, but they also can be very frustrated. And because sometimes if they misbehave or don't behave in a desired way, they think they're being a bad parent. So that comes into play as well. So your assistant is supposed to take radiographs with a kindness, gentleness, but being firm. And if they can't do that, then it's your turn to come and help out. And that's the difficult thing, because the question is, are you better than your staff in taking radiographs? And there are times I have to jump in and take the help with the radiographs, and I have a knot in my stomach because I wish that I could do a better job and do a better job. And so when I'm successful, I walk away thinking, oh boy, I really need to train my staff, and because they are better than I am in many regards. And one of the things I always try to check is asking, how old are you? Now, why is that question important? Because when a child sits down in a chair, I want to be able to kind of visualize what am I expected to see intraorally. And we have this probably a map from many, many years ago. And over a period of time, it has changed. So the dentition has changed, but yet they're different. At the same time, they're the same. And some models, and we can use these models to show parents as what we're looking for and what we can explain in terms of what they can expect to see. And we can explain better when we compare it to the radiograph, because when we pop out the x-rays, they have no idea what it is. But by using a model, you can compare and you can visualize and help them understand better as to what you're trying to get. And one thing to remember is the child can look older than really is. So for example, a child that looks like a 7-year-old, maybe only 5, but because he or she is big, you subconsciously expect the child to behave like 7-year-old. But yet the child may be only 5 emotionally, mentally, and so forth. So we need to keep that in mind as well. And so another way is a risk assessment in terms of asking how long is the tooth going to stay, especially if the child has caries, because that's going to help you by asking how old the child is and for you to prognosticate as to where the child lies in this spectrum. So let me ask you this question. How old is this child? Okay, in the interest of time, let's dissect this radiograph. The child is in early primary dentition, right? And the roots of the ENF are starting to melt away, but permanent teeth cannot erupt because there's a lack of space. So you would guess this child to be more than 5, but also about 7 years old. But also keep in mind the child can be dentally advanced in age as well. And while I'm doing that, I'm observing the body language. I'm observing the body language of the child. Whether the child is apprehensive, relaxed, and one of the keys is the child crossing their legs. I know they're very comfortable. So what do we want to achieve? We want to achieve where the radiograph can be ascertaining or confirming our clinical impression. For example, there's a swelling right here, and you want to know what's happening. So the radiograph will reveal this. So it works in sync. So we have to take the radiograph if you want to see what we want to see. That's the bottom line. How to take radiographs without getting bitten. One time, a colleague of mine said, you know what? I got bitten today by a little child. And he bit through my glove. And look. So I said, let's take a picture. So there it is. Always watch out for a cute child, because the child knows he's cute. Everybody told him he's cute. And then they can turn into this. So keep that in mind. Okay, taking radiographs. So traditionally we've been told that taking radiographs of the upper anterior teeth is a patient is in a Frankfurt position, and the degree is about 60 degrees. And that's been traditional. And this is what you see once you take that radiograph. So one day, I couldn't really figure out all these different angles. So I asked, chairman of the department was covering clinic that day on my undergrad program. And I asked him, Dr. Stolman, how do you memorize all these angles? And he says, I don't know any of the measurements. And I said, well, you're the chairman of the department. How come you don't know? He said, Jacob, listen, I look at the child and I visualize what I'm supposed to look. And then I see it, then I put the film, I put the cone, and I take the radiograph. So it's like you're a superhero and you visualize what it's supposed to look like. And then thereafter, you just put the film and the cone and take the radiograph. So I think that's a very important skill. I've never forgotten that, is forget all the measurements. Of course, in the beginning, you might need to do that just to get certain baseline. But important thing is knowing what you want to see and put the film, put the cone, and take the radiograph, because that's what you want to see. And you get great radiographs time after time because you can visualize beforehand, because you have a superhero powers. And then you won't get the radiograph here on the right, where you got cone cut on the bottom and you got cut the roof on the top. So you won't be getting that. And sometimes you need the help of the parent. And they'll be able to. I'm so glad that over a period of time, many years ago, dads weren't that very useful. But now dads are much more involved. So it's really good to have the dads more involved in helping out with the behavior management. Let's go to the bottom. Now, in terms of the upper, my assistant always says, we'll take a picture of your nose. So this one, we'll take a picture of your chin. So look up as high as you can. And the best way for me is to just cup the chin and take the radiograph. And if you can visualize what you're supposed to see, that's the radiograph you'll be taking. And on the upper, visualize again. Exactly. And you'll be able to take that radiograph. The bottom, straight across, 0 degrees, but literally straight across to the child. And then take that radiograph. And slide to the upper left. The child moved, so one of the things I always caution my staff is do not turn your back on a child because you don't know whether the child has moved as you're ready to take the radiograph. So keep your eye contact with the child, have the child look at you, and then you can take the radiograph knowing the child is still. And of course, never bend the film. Now, this is kind of a classic one, right? In the sense that this bite wing was taken in a little upper angle, and the one on the right is straight across. And I always want straight across because of two things. Number one, I want to see the pulp horns. And I want to see caries straight across. And those are very important ingredient to great bite wings. Now, the anatomical difference between adult versus a child. You can see on the adult here, ignore all these restorations, you can see the line is very much straight, where is a alignment of these on the primary teeth is very acute. And let's look at the lower. Alignment of the permanent teeth is very smooth, it's smooth curving, but the primary teeth is much more acute. So when we are taking radiographs, and I see a lot of assistants who've been used to taking bite wings on an adult make a mistake on the child is they kind of aim about here, where the distal of the cuspid, and you'll get a overlap on between the first and second primary molars. So they must always aim for here. If they aim to be aligned this 90 degrees to the cone, then this portion at the interior will be a bonus. I almost guarantee it. If you aim right here, and that's what I showed my assistant, have the child bite down and smile big, and if you gauge right there, then you'll always automatically get that. Okay, bite down, big smile, and you can look and take. And you'll see the pulp horns as well as the contacts. Now, another important thing is always make sure the radiograph is, you take the radiograph right in the middle. Because here is a partial P of the lower and with a little bit sprinkling of the top, because otherwise you can miss, especially on a young child, about especially 5 or 6 years old or 7, you're going to lose out on the ectopic eruption of the 6-year molars. And in a trauma case, you want to know how much the tooth is intruded. So you want to take extraoral picture here, because basically you're trying to find out tooth is like this, whether it's just impinging on a permanent tooth or whether it's bypassed right here on the top. That's why you're trying to visualize. Everybody wants to go to heaven, but nobody wants to die. Maybe kind of dramatic, but I always try to convey to my staff, look at the radiograph before, because time after time after time, you want to try to get the same radiographs so you can gauge. For example, this is the two ectopic eruption of the upper cuspids. So I extracted the 2 primary cuspids with a space maintainer, and you're checking over a period of time the eruption of the permanent cuspids. And so if you try to get that same angulation each time, and that's very critical. In terms of soft tissue, sometimes in trauma, fragments get embedded in the tissue. And so it's important to make sure that when you can put the film inside, right underneath the lip, and you can take exposure time should be decreased by about 25% of the normal time, and you should be able to see it. Otherwise, it would be too dark. You cannot see it. And this, my old photograph, I keep as a reminder. I was called up about 2 in the morning as a resident, and plastic resident has come in and sutured the lip. Then I noticed this fragment is missing, and I don't have the radiograph with me anymore. But so we took a radiograph, and the fragment was right there. So plastic resident had to remove the suture, take the fragment out, and resuture. So we're trying to avoid re-traumatizing the area. Now, let's move on to radiographic interpretation. Count the teeth. Now, we've been told from dental school, count the teeth, count the teeth, count the teeth. And yet it's very important. Let's give a moment of looking at the pan. So let's dissect this radiograph. We have here 2 central incisors, and we are missing the lateral, right? And this looks like a cuspid too. We're missing a cuspid, right? Because you can see how long that is, right? Kind of rare to be missing an upper cuspid, but it does happen. How about this one? Second premolar missing here, kind of premature hypodevelopment of the second premolar there. And something not right here, something right here. Now, in terms of missing teeth, sometimes it can be associated with certain syndrome like ectodermal dysplasia or incontinentia pigmenti, but sometimes they're just missing teeth. And that's where the family history becomes critical, because when we talk about missing teeth, parents say, oh, so-and-so, or I am missing teeth, or my husband is missing a tooth, or here and there. All right. How about this one? A lot more missing. Missing a premolar here. Succedaneous tooth here, 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 here. But missing here, missing here, missing here, missing here. And maybe hypodontia as well here. So these are always good to count the teeth in that regard. Sometimes they're missing teeth, but sometimes they have extra teeth, okay? Supernumerary. Pointing north, so it probably needs to come out. You go, wow, that's, I've seen those before. It's elementary. How about this one? So let's work it through. You have a central here, another central here. You have an extra tooth here. You have an extra tooth here. So this one is pointing south, but there are 2 of them. How about this one? You kind of go, mamma mia. So there's a succedaneous tooth there, 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 but you got a lot more teeth here. And sometimes it may be associated with a syndrome like cleidocranial dysplasia, but sometimes they just have extra teeth. Now, this is an interesting case. You see here, succedaneous, here, here, replacement here, 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 crowded here, no space. Tooth is there, but no space. Tooth is there, but no tooth here. Okay. So patients start ortho, and sometimes when the orthodontist sends you the pan, it's really hard to tell, but she was undergoing ortho treatment at the time, about 13 years old. And then one day, after she was done, sometimes we build up the tooth so that it don't lie on top of each other, tip over. And she chipped part of that. So I said, well, let me see how long the root is. Let me find out. And guess what? She had a supernumerary tooth growing. And that was the original pan. So let's go back. Let's see what happened here. If you look very carefully, you see a little faint tooth there that was missed. It was growing, but it was so faint, could not tell. So always keep that in mind. The teeth can start grow, gemination-wise, grow over a period of time, calcify, and you won't be able to see it for a long time, but never ignore it. What about this one? Everything looks to be okay. Then you see this. Then you see this. Then you go, yeah, there was something going on here. So whenever you suspect something, of course, take a PA because that's much more definitive. Now, of course, if you have cone beam, you're a rich person, you have cone beam, then you can take those. But otherwise, you can refer to the oral surgeon to have that taken care of. Okay. Sometimes roots can be easily visible right here, and 2 rows of teeth, and that's after the extraction. And you can see whether the teeth actually, permanent teeth missed the primary teeth. And actually, this is a proper eruption pattern. As you know from undergraduate program, that there's a canal called gubernacular canal. And I always give a quiz to my residents. And so the tooth is supposed to erupt through the gubernacular canal. But in this case, many times it doesn't. It comes right under the primary teeth. So people think that that's the way it's supposed to be. But once the tooth was extracted and it comes, erupts, the tongue moves it forward, get free orthodontics. And that's what you get. Here, another one. In hindsight, I asked myself, should I have extracted that tooth? At the time, I said, no, the tooth is too far down. I want to let it grow a little bit. And finally, when patient said she's uncomfortable, took the tooth out, and that's the way it was. Now, this is an interesting case. So look at tooth letter J, right? It's uneventful, benign, working out fine. Then one day she came and said, this tooth is erupting buccally, and the tooth is becoming uncomfortable. And I couldn't really see where the palatal root is. But as I was extracting it, this is what I saw. And of course, now that you see it, you can almost guesstimate where that was. But because of the pulp and root canal, you could not really see. But of course, hindsight is better. But always remember that, like this orange peel dessert, that the roots of the primary teeth flare a lot. And we can explain to the parent because they want to house a permanent tooth underneath, inside. So that's why they flare out. And sometimes they don't all resorb equally. So that's what happened. Let's look at some pathology. A friend of mine came to me and said, I got a new pen machine, and probably cost him a price of a Porsche. But he said, look, isn't that fantastic? Look at this quality of the pen. I said, yeah, the quality is great, but you got an abscess here. He said, I know, but look at the pen. It's gorgeous. Right here. And months later, he came back to me and said, okay, I cleaned it up just for you. But look at, and I told him, your pen is just gorgeous. Now, when you look at teeth, don't just look at teeth. Always look at the trabeculation of the bone as well. Do you see something here going on? Riding up. Right here. So what is it? Let's take a pen. Mamma mia. That's the lesion over there. And one of the differential, which is scary, is ameloblastoma. But one thing about pneumonic, about traumatic bone cyst, it's right between the roots apices of the teeth. So it turned out to be traumatic bone cyst. Whether she was a cheerleader, whether she propagated that, nobody knows. But good thing is the treatment is you open up, you clean it up a little bit, you close it up, and the bone fills up. Some of the artifacts, please always try to take the earrings out if you can. Sometimes it's so hard to get those out. Sometimes we do take it, but whenever we can, we try to get rid of the artifacts. Clark's rule. I could never figure out what Clark's rule really was. So one day I kind of looked at it and I said, how about this? So if you, I know you can't see me, but if you can just imagine and just put two index fingers together in front of you. So left index finger, right index finger on top of each other. And just move your head. So one that's palatal is the one that moves with your head, and because your head is the cone, X-ray cone. And if you move to the right, he moves to the right with you. If you move to the left, he moves to the left with you. Okay? That's my version of Clark's rule. Done. So, how many root fractures are there? And the answer is just one. So let's review that. So let's say on a trauma case, your X-ray is going through the middle of the tooth right here, and then it forms that little halo on the top. That's where this portion is shown, and then it kind of diffuses down, so you can't really tell what's going on, and the bottom is showing up as much more distinctive right here. And if you take a different view, straight down, then you see there. So they recommend that if you suspect a root fracture, Andreasen recommends that you take a different radiograph at least 15 degrees apart to distinguish that. Why is this important? On a permanent tooth, this is important because you want to know how much you want to close and approximate before you splint the tooth. Also, prognosis of the tooth is important. Apical third is not as important. Middle tooth, not great prognosis, and prognosis if it's a cervical. Now, of course, checking the root fracture of primary teeth is okay, but bottom line is you're going to be probably extracting it anyway, so it really doesn't make that much of a difference. Usually they do not heal. And once again, middle, if you suspect something is happening, then usually the lesion is larger than you think, and you want to try to find out how close it is to the developing tooth follicle. So you want to check that. Very important. And I know what you're thinking. Did this person hit the pulp horn? It's hard to say, unless you dissect the tooth. This is a classic radiograph. Large occlusal caries lesion. You kind of go, I wonder what's happening up there. Well, with that large occlusal caries, the tooth is abscessed. So whenever you see a large caries lesion, always take a supplementary X-ray to ascertain whether the tooth is vital or non-vital. Okay. And of course, you have to be precise in your radiograph before and after, just a picture of before and after, making sure. And if you take the post-op X-ray, make sure that you can see the pulp horn, because you want to stay away from the pulp horn. And I know you're focusing on this a little where I didn't polish this very well, but I didn't wear a loop at the time. Okay. And here, pulp horn. It abscessed. It teaches you how to be better. Not all nicking the pulp horn turns out an abscess. This one became internal resorption. So don't expect just an abscess. Sometimes it gives you a different manifestation. So whenever you take bite wing, make sure it's going right across the middle, and you avoid, you check the pulp horn. Well, you avoid it when you're preparing it, but you want to make sure that you can check the pulp horns. Pulp horn again, abscess. I think I've driven that home. Now, this patient was very sensitive, and you've seen those small pinhole caries, and then it becomes a cavern. And so bite wing has to be just straight across where the buccal and lingual cusp are coinciding, because you can see then how much of the tooth is laying down dentin and healing. And once it heals somewhat, then you can go in and clean it up if you need to. Sometimes we do dentistry, not only for patients, but for another dentist, I think. And this is where, I don't know if this is a pulpotomy or just a glob of amalgam, but you can see it abscessed. You can also check the degree of bruxism in primary teeth. A lot of children tend to grind their teeth, and could maybe associate with GERD, but you can see it's going straight across. And sometimes they're sensitive, sometimes they're not. If they're sensitive, sometimes we can put a little sealant or composite on it. But you can check from one checkup to the next as the degree of attrition. And sometimes if they grind really severely, they fracture. Restoration. This is a really severe one, where the cusp tips are worn down and they're almost turning flat. You need to build them up to save the tooth. And whenever you have very large carious lesion that you're going to be doing pulp therapy and the crowns, always be mindful and take a radiograph after you treat, because putting a crown on second premolar is a bully, so to speak. You'll take up the space of the first. So this one is going to leak and probably will fail. So you always need to keep that in mind to push this one back, or cement first, and then the second. Just a tip for you. And I always take a radiograph if I'm crowning the permanent molars, because many times it snaps loud, but you think it's fitting well, but many times you find out that the margin is opened incredibly. So you want to make sure that they're tucked in and they're minimizing leakage. Traumatic injuries. You're not worried about intrusion. This is an avulsion, almost labial luxation. So you implant it. Usually we don't implant it, but I happen to do it because the parent really wanted it. So did it, and it works. So once again, looking at the apex, knowing where it's supposed to be, this is a cuspid that's intruded and erupted. This is one case I made a mistake. The tooth was almost entirely avulsed. So I cleaned it up, put the tooth back in, and then I took a radiograph and I missed a little fragment. So always when you check the tooth, to make sure that you can check the apex end to see if any apical portion is fractured. You can also check here. You can see straight across on this one. This one, they had a poor splint, so the two fragments rubbed on each other and became abscess. Pulp exposure. And here, I tried to take the same radiograph, but unlike Andreassen's, missed out, but you can still see over a period of time the healing of the tooth. And that's what you want to measure. Once you know it's healing, the fistula is gone, and you can see the root starting to grow with the Hertwig's epithelial root sheath. And it closes up. Follow-ups. As you're learning how to do pulpectomy, for example, I always encourage my residents to take a radiograph immediately after treatment. It's a learning experience because you don't want to wait 6 months or a year before you find out whether you did it perfectly or did it properly or not. So take the radiograph, and especially if you didn't go all the way down to the apex, you want to make sure you monitor that tooth. That, and make sure you get your sushi out and you fill it. In one moment, please. And burnout. Mesials. Always watch out. This can mimic caries, but many times it's just a burnout of the radiograph. Caries. If you see a small dot, please make a note. And sometimes you might want to check in 6 months, because this was taken May and March, about 10 months later, and see how big it got. Child missed the 6-month appointment and then came back and said, my tooth is bothering me. So there it was. So always make a note and maybe take another radiograph at the 6-month time. Now, caries always don't go get this big. Sometimes it just is dormant, but that's what you want to confirm. Now, this is from my associate son, pediatric dentist. One day he showed me the radiograph. This is a parent who never wanted x-rays, and then suddenly decided to get braces. And so my son convinced mom that maybe we should take a couple of bite wings. And he sent me this and said, there's something not right with this. And initially I was kind of baffled. I said, what is it? And he said, look at the distal of 19. Something is happening there. Because if you compare with distal of 30, yes. So he was referred to endodontist. It was external resorption. Very rare. I don't remember ever seeing one. And so that tooth was taken care of. So always not just caries, but look at the root and trabecular bone as well, because we talked about that traumatic bone cyst. And always check over a period of time the pulp therapies that you do. Because I find if you do a pulpotomy, the tooth lasts about 2 to 3 years. And when a permanent tooth is coming down, usually it's just supposed to undergo apoptosis. But in this, many times when a tooth had received pulp therapy, it seems to just kill over and turn into an abscess. So that's something to monitor. Especially if you don't go down all the way to the apex. If the tooth was non-vital, it's important to monitor over a period of time. And of course, reminder, always check the middle to make sure that you don't miss any ectopic eruption. And you can also check here. If you put a spacer, this was a crown loop space maintainer, and you can see how the permanent teeth are just trying to come in a little bit. And then if you cut it, you can just allow them to erupt. So that's another way of checking the level of eruption of the permanent teeth with your bite wing. Okay. Let's do another quiz. Let's dissect this one. How old is this child? So you see 8 and 9 erupting, lower incisors are erupted, 7 and 10 are erupting, 6s are erupting, but upper 6 are not erupted. To me, one of the situations is because the child is very crowded, so permanent teeth really it will take a little bit more time for upper 6s to erupt. And this child happened to be a wiggler. And he had wiggly tooth, so he just wiggled it all out. So he's a capitalist, making good money. So you see, let's see a 10-year-old child. You see this, and you ask yourself, okay, 10-year-old, I want to check where the primary cuspids are. Especially if you see a lot of spacing, and you want to check the mobility of the primary cuspids, and if they're mobile, then you definitely want a radiograph. Because usually they should be erupting this way, riding on the distal of the laterals and just erupting. But if there's a lot of space, they're not doing that. They're missing somewhere. 2 ships in the night, they're missing each other. And so they go like this. You extract both sides because you want to keep the midline straight, unlike Tom Cruise midline, which was about here. And you have that bilaterally, and you can see where they were missing each other. Ectopic eruption, you can continue to check the progress of your modified Halterman's technique. Lower as well. Upper is about 3% of the population, lower is 1%. But when I started teaching at Loma Linda University, it seemed like everybody who had was living in Loma Linda, because I saw lots of mandibular ectopic eruption, which was interesting. Okay, so I harped on this one before, but I really get frustrated when my staff do not take appropriate radiographs because I cannot diagnose properly. Upper one, this one should have been much straighter. And this one, Are you kidding me? You bent the phosphor plate? So whenever staff made a mistake, I was very passionate about correction. But one day, my assistant, who used to hand me the crown this way, suddenly handed the crown this way. Taught me a lesson. I said, hey. And she said, oh, must be subconscious. So from then on, I've changed my ways. I'm much more positive in reinforcing. Anyone can become angry. That's easy. But to be angry with the right person, to the right degree, at the right time, for the right reason, and in the right way, that's not easy. And somebody said, honest criticism is hard to take, particularly from a relative, a friend, an acquaintance, or a stranger. So when you do your evaluation, I hope you keep that in mind as well. Thank you. Now, I was watching one day, Sunday morning TV program, and they talked about Pappy Van Winkle's bourbon brewery. And I don't drink, but I thought his mantra was very kind of apropos. Pappy Van Winkle Sr. said, we make fine bourbon at a profit if we can, at a loss if we must, but always a good bourbon. And I changed that to dentistry. We deliver great dentistry at a profit if we can, at a loss if we must. And sometimes we make a loss. Yeah, it's not profitable all the time, but always, always deliver great dentistry. And I end my presentation always with, I hear and I forget, I see and I remember, I do and I understand. Ancient Chinese proverb, revised Korean American edition. And in the words of American philosopher Frank Sinatra, do, be, do, be, do. Thank you very much for your kind attention. Hello, so the question I have is 5 to 6 year old grinder, what do you do? It depends on the degree of grinding. If they can wait, so to speak, until the 6-year molars erupted, and when I seal the 6-year molars, because they do have many times deep pits and grooves, then I build them up a little bit so they'll be wearing down on the sealant and not the teeth, preserving the teeth. And that's what I explained to the parent in that regard. And that was another question about bruxism. Another question was, what material do you use to obturate canals after pulpectomy? I use zinc oxide powder with Zoe BNT liquid. The reason is if you use Zoe BNT, because it's a lot more fiber, you can. It's too much. The tooth will not resorb, or the tooth will resorb, but the material will not resorb. So what I do is I mix the zinc oxide powder because it's much more resorbable over a period of time. But because I'm using Zoe BNT, it sets faster. And so that's another one. Ectopic eruption. This is where the 6-year molar on the upper and sometimes about 3% on the upper, about 1% on the lower, comes in and starts to impede on the distal root of the second prime molar. And so that's really can be very disruptive in terms of growth and development. However, one thing we noticed over a period of time is that those teeth do not tend to abscess. They just take up the leeway space. So unless it's a cardiac patient, then you have to do much more treatment in terms of extracting those teeth and distalizing those thereafter. So when you looking out for ectopic eruption, always check to see at age 5 where they are. And so when you take your bite wing, you can just see, and of course, make sure that bite wing, the line occlusion is right on top, so you can always check that. Question is, can you comment more on the prognosis of root fracture of permanent teeth varying depending on the level of the fracture? So kind of consensus is if it's apical third, it will heal much better than if it's a middle or cervical. And I think it really comes down to bacterial infiltration, because cervical bacteria is going to infiltrate and then you're going to lose that. But also if you, let's say you remove, and so if you splint it properly, then it should really not have that much problem. And if it's a root fracture, remember always it's a fixed, like putting a cast on, fixed splint and not a flexible splint. Okay, let me clarify. I'm talking about zinc oxide powder, not RM, because RM still has a little bit of fiber in it. So sometimes you see the teeth, primary teeth roots resorbing, but you see a little so-called stick of RM still left inside the bone. So I don't want to see that. So I'm using a zinc oxide powder, and you can get a bottle of it, and it will last you forever, literally. So that should help. Best way to control a kid? Great question. I think if you know that, I think you hit the jackpot. But always treat a child with respect. And everybody has a bad day, and even a child has a bad day. But one thing I like about children compared to adults is if something bothers them, they let you know. And so I can modify, I can do whatever I can to help. And I always told my resident to address child as not a kid, but as a child. Just so you can have it in your mental that to show respect for a child. I think that's important, especially with teens these days. I think they're much more sensitive to those things. So I think treating children with respect, I think it seems like kind of an obvious one. At the same time, it is an important aspect, I think. Cementing stainless to crown, I use 3M cement. It's more expensive, but I just like the clicker. So I've used that. And one thing I try not to do is it's not to be too cheap on cement or dental materials, because when it comes to children, you want that to last for a long period of time. What is the best treatment for tooth decay for kids? Well, it depends on what you see on the radiograph. For example, if the child has rampant caries, you want to control the caries status, but also at the same time, you want to enforce preventive aspect and regimen. And that's very important to work with parents. There's a question. When you treat ectopic eruption, I saw on your x-ray showing a band on second premolar with a wire attached to the band. Can you see what you did there? So it's called modified Halterman technique, named after Dr. Halterman. And what you do is you take an impression, or you put a band on the second premolar, and then you send it to the lab with a remark with the model saying you want a wire that soldered and that goes distal to the ectopically erupting 6-year molar. And then when the appliance comes back, you put a button on, you bond the button on the 6-year molar, what you can see, and then you put an elastic band after you're cementing the band, and then you distalize it over a period of time. You might have to do it a few times just to create that space. I'm so used to seeing my audience, but this really is a little tricky not seeing. At what age do you recommend the first panoramic film? Usually about age 7, or unless you suspect there's something happening before. But I think that development-wise, about 7 to 8 around there would be probably not a bad idea. What does SDF look like on an X-ray, and can you tell if decay is arrested? You can only tell that over a period of time. And SDA looks like a little fine white line, but unlike icon, which is translucent. So if you use icon, then you have to, and the patient transfers to another office, you have to tell them that you used icon, and so that the other dentist doesn't think you didn't do anything about it. SDF has its place, but you have to really monitor, because if the child has rampant caries or the cooperation is not good in terms of preventive hygiene method, and that's when they get into a problem over a period of time. In the interest of time, I'll answer one more question and then we can sign off. What are the key points in the diagnosis of external resorption? I think one thing is taking the radiograph that's proper so you can monitor over a period of time to determine whether it's external resorption or internal resorption. And sometimes the radiograph is the only way you can tell. Or if you have cone beam, of course, you can tell better that regard. I think that's one way of checking whether it's external resorption or caries or anything like that. And usually it follows trauma to the tooth. But like the case before, we don't know if the child was traumatized or not. So. I think that's all the time we have at this time. So I thank you for your kind attention. And I bid you farewell.